So this is the time when we have to start learning properly, because I think within 3 months we'll be having, within maybe 2 to 3 months we'll be having our exams. So if you are right now procrastinating, try to find out where this vicious cycle, which loop we have got stuck in, and try to change it. And I'll tell you, so especially those who are repeaters, learn from your mistakes which you have done last year, especially while your preparation or while attempting to your exams, and always try to improve. And you should know that it's not just working hard, but the smart work which matters the most. So just studying is not enough. You have to have an MCQ oriented approach. It's also for the regulars or the freshers who are planning to write the exam this in the first attempt. The smart work, that is especially the MCQ oriented approach, which matters. So studying up whole of the Harrison, whole of the Bradley, and then attempting the questions is not enough. Take a small section, try to answer the MCQ, and then go back and then read again. And never give up, especially during this difficult times. And you should be determined to do your best, and always self-reflect. And you should know that put your maximum effort. And once you are motivated, I think these kind of videos and all classes would be more than enough to get you motivated. And once you motivated, you have to keep this habit going. So any habit, anything you keep in your daily practice, if you keep it for just 21 days, 21 days, if you keep it regularly, if you are practicing it regularly, it becomes your habit. So till 21 days, persist, have a habit of keeping it persistent, and then it will become your habit. So if you are planning to wake up at 6 a.m. Or 5 a.m. or have a specific timetable, spend a certain amount of time for your studies, try to be persistent and consistent, especially in that, for about 21 days, and definitely it will become your habit. And put effort into that and train your brain. Never think that okay, I'll get a rank 500 rank, 600 rank because I'm a fresher, and institutes are not my cup of tea, and they are actually out of my league. No, actually we have got something called neural plasticity. So if once the time you think that, okay, I want to be in AIMS, JIPMER, PGA, or Sri Chitra, and you put your effort, the neural plasticity comes in, and no more synapses are formed. So if you train your brain hard, definitely you will achieve your goals. But it may take time, and it depends basically on your willpower and your efforts. So that will help you in your growth. And definitely one thing is that it's not the competition with others which matters the most. It's the competition within yourself. That is, you should be a better person than what you were yesterday. That is the one which matters the most. So with this pep talk on, or a bit of motivation, we'll start this session today. So this is regarding multiple sclerosis. So I'll tell you that multiple sclerosis is a demyelinating disease for sure, that which all of you know. But before that, you should know that it's actually just the body. If you consider this multiple sclerosis as a part of a demyelinating disorder, it's just the body. It has got a head and a tail. The head will be considered like any demyelinating disorders. Lots of demyelinating disorders are there in the human, while considering the diseases within our human system. And that will consider the head. And the tail would be the newly found out demyelinating disorders like NMO and the Mock spectrum kind of disorders. So we have to know this head first. So if you have a deja vu of what this question comes up, if you see this question, you may have a deja vu, because this same question, similar structure, was asked in the peripheral nervous system module as a first question. So try to answer this question. So I'm launching the poll, and you should understand that if you get it wrong in this question, then you should understand there is something wrong in your study technique. If you are following this Fine Neurophilia series and you are correctly studying everything, there is something wrong. You have to go back and study, especially the peripheral nerve modules or peripheral nerve system, what you had completed. Yes, everybody give an attempt. Yes, I think those who are viewing have giving their full attempts. Uh, yes, few of them have got wrong. It's okay. Maybe they are new to this series. It's okay. Others have got it right. Yes, it's the oligodendrocytes. So if you remember in the peripheral neuropathy series, we had discussed regarding the support system of the central nervous system. They are 5 in number, and of which the oligodendrocytes are the ones which help form the myelin within the central nervous system, and the counterparts in the peripheral nervous system are the Schwann cell. And astrocytes are the ones which give nutrition and forms the blood-brain barrier within the central nervous system. So these are the just a revision of what, and these forms the basics. So as you know, oligodendrocytes are the ones in the central nervous system, and one oligodendrocyte forms multiple covers multiple neurons within the central nervous system by forming myelin. And these are type 1 myelination occurs in the central nervous system, and type 2 within the peripheral nervous system. And what we are going to study is about demyelination. So there is this, that is destruction of myelin, or something is happening to the myelin. So first of all, we should know what this myelin is. You must have learned that it is something like a fatty substance or something, but more to it you should understand, because the pathology, understanding the myelin will help you understand the diseases which affects the myelin. So it is actually 40% of it is actually water, and 60% is dry mass. And of this dry mass, 3/4 is made of lipid, and 25% is of proteins. And any pathology, even affecting the water within this myelin content, will cause demyelination. So that will be what affecting. So any acid-base imbalance or water disturbance that occurs within the within our human body, as occurs in case of what you call osmotic demyelination, that is central pontine myelinolysis, extra pontine myelinolysis, etc., will cause demyelination. So that is the crux here. And as you know, this lipids and proteins, as we said, lipids are 75%. That is why it forms the insulation with above the nerves, and proteins are 25%. And when you go through the Harrison and Bradley, and we see lots of molecules coming in, like antibodies against the myelin basic protein, and you know the separate entity of disease of MOG, that is myelin oligodendrocyte protein. So these are actually contents within the protein contents within the myelin. So these when get affected due to the various disease processes, results in demyelination. So galactocerebrocyte, if get affected, it results in there's dysmyelination syndromes, as in pediatric demyelination syndromes. Sphingomyelin getting affected, cholesterol getting affected are causes of pediatric dysmyelination syndromes. So if you consider the disease of myelin, it could be divided basically into dysmyelinating and demyelinating disorders. Dysmyelinating ones are the primary disorders of the myelin. So the primary metabolic disorders of the myelin. And demyelinating ones are the destruction of myelin. And some diseases are hypomyelinating, that is reduction of myelin synthesis, which could be due to congenital problems, or delayed myelination. So we will be concentrating mainly about demyelinating, but we'll have a quick brush through the dysmyelinating ones. So the dysmyelinating ones are basically, as I told you, are primarily metabolic problems, that is metabolic problems affecting the myelin. So they include basically the pediatric dysmyelinating disorders, as we have studied: adrenoleukodystrophy, ALD, that is ALD, metachromatic leukodystrophy, Krabbe's, Alexander's disease, Canavan's, PMD, phenylketonuria, etc. And the demyelinating ones is not just multiple sclerosis alone. It contains a whole array of diseases. As I told you, if water is, even if water forms a component of myelin, so if water is getting affected, as we can see here, central pontine myelinolysis is actually a central pontine myelinolysis is actually occurring due to, I'll just take the pen. I was trying to take the pen. Marker. Okay, fine. So central pontine myelinolysis you see here, right? So that is a problem within the water content. So all this autoimmune, infectious, toxic metabolic, vascular, due to the decreased blood supply to that region, as in case of Binswanger's disease, etc., causes demyelination. And multiple sclerosis is just one cause of demyelinating disorder. So this table is from Bradley. And if you see, I had you know about reading the MRI. So if you know what is this MRI, if you see this MRI, you know that the gray matter is whiter in color and the white matter is darker here. This is due to a tissue destruction process that this dark matter is getting whiter, or that is T2 hyperintensity, because CSF is white here and gray matter is whiter and white matter is darker. So in this T2 weighted image, we can see that there is actually symmetrical white matter hyperintensities, and there is symmetrical white matter hyperintensities with stripe-like appearance here. So if this symmetrical appearance helps us, appearance helps us differentiate the dismyelinating disorders from a demyelinating disorder. So this symmetrical, this stripe-like appearance is called a tigride appearance, which is seen in metachromatic leukodystrophy, also could be seen in Pelizaeus-Merzbach's disease. So if you see here, this is also a T2 weighted image, because water is white here, gray matter is white, and white matter is darker. So T2 weighted image, if you see here, there is bilateral white matter hyperintensities. And I would suggest, I would like to say that it is asymmetrical. But if you argue with me, I would have to give in and try to say that it is symmetrical. So one more adjective to add in case of how to differentiate between a dismyelinating and demyelinating disease would be that more than symmetricity, we have to add that whether it is a confluent white matter hyperintensity or a patchy white matter hyperintensity. So a confluent symmetrical white matter hyperintensity will point towards a dismyelinating disease, and a asymmetrical patchy hyperintensity would point towards a demyelinating disease. This is a typical MRI of a multiple sclerosis patient, and this, as you see, is a periventricular white matter hyperintensities radiating from the periventricular region. These are actually the Dawson's fingers, very well seen if you see the sagittal section of the MRI. So with that, we'll go to the next question. So these modules are to help you read and read the text and emphasize on the portions where you must have missed out while reading the textbook. So try to answer this question. You must have, while going through the text or while in your clinics, you must have learned about the Uthov symptoms. So Uthov symptoms is characterized by which of the following features? You can answer this. Every time you see a question, make it a habit. So that is why I have taken pains to put this as a poll option. So try to, you have got enough time for that also. So take time, read the structure of the question. It may seem very simple. Then read each option, then try to answer. That is so okay. Options are sorry. Okay, most of you have answered it as may occur with physical exercise. Yes, right. So they are actually bilateral visual blurring which occur due to heat sensitivity and not due to cold or other symptoms. And it is not due to decrease in body temperature, but due to increase in body temperature. So what is this heat sensitivity in multiple sclerosis producing these transient symptoms called Uthov's phenomenon or Uthov symptoms? So this occurs due to transient conduction block. So as you know, the patient with multiple sclerosis are perfectly healthy except for these kind of transient, these kind of focal symptoms. And these patients, when they try to walk or do exercise or get a fever, then they develop these kind of transient symptoms, and so also gets exaggeration of their symptoms which they were having. So if you want to give an advice to them to go for a perfect exercise for them, the ideal exercise for them would be to go for swimming in cold water rather than a heated exercise. So I'll go to the why this occurs. For that, to understand why this Uthoff phenomenon occurs, you have to understand the physiology and pathophysiology of multiple sclerosis, why it is occurring. As we had seen before, these are the oligodendrocytes, which gives multiple myelin sheets around the axons in the central nervous system, and they are perfectly working in sync, so that there is message transmission within the brain. Due to some disease process, there is destruction of both the oligodendrocytes as well as the myelin. You can see what are these cells. These T-shaped cells, these are actually the T cells. So these T cells are the main culprits regarding which causes the multiple sclerosis. And further, there is addition of B lymphocytes. So both T cell mediated as well as the humoral immunity both acts in causing multiple sclerosis. If you read further in the textbook, then now you will get to know. And that is why all the disease targets are acting on both T cells as well as the B cells. So in a normal conduction, as we have discussed in peripheral neuropathy chapter, it would have been a saltatory conduction. It would have gone at a speed of 70 meters per second. But when when a nerve is stripped of the myelin, the speed is reduced. And why it occurs, we will see. So when the myelin is when there is saltatory conduction occurs due to conduction along the nodes of Ranvier, and in the nodes of Ranvier we have the concentration of sodium channels, and there is jumping of these conduction across these nodes of Ranvier because there is insulation with this lipid-rich myelin across these internodal area. And if you see, there is sodium across. So you may think that this is the sole reason why we have this saltatory conduction. And when there is a stripping of this myelin, there is exposure of sodium channels. So there is multiple sodium channels which open up here. So that causes the time consumption of the sodium channel opening and thus slowing of conduction. Yes, that is one of the reason why, because of the multiple exposure of this sodium channel in the naked axons, that causes the slowing of the conduction across the this naked axons, that is the demyelinated axons in case of multiple sclerosis. But there is one more cause for this, that is in between this myelin, that is in the nodes of Ranvier, there is potassium channels also. We know there are sodium channels, potassium channels, also there is sodium potassium ATPase. There are also potassium channels in between also, that is in between the internodal area. The specificity of the peculiarity of this potassium channel in the nodes of Ranvier is they are slow channel, and the speciality of the potassium channel in the internodal area is they are the fast channel. But contrary to what we think, the fast channel ones causes repolarization. So if you remember your first year physiology regarding action potential and all, the repolarization this slow potassium channel actually causes repetitive firing of the action potential. So if this fast potassium channel causes repolarization, and if it is exposed, it causes dampening of the already slowed action potential in case of demyelination. So if this is stripped off, this layer is stripped off, along with the sodium channel getting exposed, potassium also get exposed, that too the fast ones. And also you have potassium here also. So of this, this one will be more exposed and there will be further dampening. So just to add the point that in Harrison, they have point out the fact that the sodium getting exposed in case of a naked axon will result in slowing. But in Bradley, one more point has been added, that is regarding the potassium channels. So with that introduction, I'll just, since I have already given you the answer for this question, I'll just want you to process that knowledge. So that is why I have put this question to you. Question number 3. Try to read it. They are long sentences, but try to read it, especially the first sentence, and try to process it within your mind. So I am asking for an incorrect statement. So sodium channel opening, as you know, is the cause for action potential generation. And I have already told you that fast potassium channels are present in the internodal area, and the slow potassium channels are present in the nodes of Ranvier. But contrary to what we see, that fast ones, we think that they fasten the action potential, but contrary to what we believe, the fast ones causes repolarization and actually dampens the potential, and slow ones causes repetitive firing and actually fastens the potential. And in all these repolarization and depolarization are balanced with the help of sodium potassium ATPase. So a step ahead from what we learned from Harrison, Bradley has given these facts. And I am just asking you a basic question which we learned in physiology. That is the wrong statement here. Actually, opening of sodium channel causes sodium influx rather than a sodium efflux. So read the question properly every time you answer. So this is the explanation for that. Action potential propagation causes sodium influx rather than efflux. So that clears the point in Bradley. So MS, if MS, multiple sclerosis, when you go through the textbooks, actually you feel that it is very easy to diagnose. But in actual clinical practice, it comes with varied presentation. And it's very difficult to diagnose. And we need to have a high index of clinical suspicion. And also we need to have a high clinical acumen. And with experience only, we will be able to diagnose MS very easily. And after having this clinical suspicion, we have to go through a clinical diagnostic criteria before starting these specific drugs for MS. So this clinical suspicion can be made by knowing MS better. For that, definitely we have to go behind the studies and know the well-known presentations of this disease. So Harrison and Bradley has gone through many studies and given us various presentations. That is the initial presentations of MS. So if you have gone through Harrison, you will be able to answer. I have put this question from Harrison. So MS, as you know, it is actually demyelination, and demyelination occurs in the white matter tract and not in the gray matter. Mostly it's in the white matter tract. And white matter tract could be in the optic nerve tract, it could be in the motor tract, sensory tract, cerebellar pathway, etc., etc. And based on this, we have multiple problems. And you should know the fact that pain is one of the most common symptom experienced by MS patients, and it is present in more than 50% of the patients. And there is one popular adage, that is, if a patient comes with symptom in one leg, so if a patient comes with a paresthesia in one leg, usually we think of IVDP or any symptom like that, peroneal neuropathy, IVDP, etc. And while examining, you find that the patient has signs in both legs, that is either reflex loss or paresthesias in both legs, or some other symptoms in both legs, then definitely have MS in your back of your mind. So that popular adage is a patient presenting with symptoms in one leg and signs in both, think of MS. So that could be, and optic neuritis in MS is usually unilateral. And if it is bilateral, you have to think of other causes. It is not that MS is, cannot be bilateral, but it is mostly unilateral. And if it's bilateral, we have to think of other diseases. And it MS presents with other diseases also. So it can present as even Bell's palsy, that is also present as tic doliorix, that is trigeminal neuralgia, facial myocemia. It can present as constipation, urinary bladder symptoms. It does not necessarily mean that you may think that it is always UMN bladder the patient would be having. If the patient has MS lesion, that is MS kind of lesion over the sacral region, then the patient may have urinary retention also. It is based on where the lesion, white matter tract, where the lesion occurs, the findings differ. And so the answer for that one, I forgot the question. Yeah, optic neuritis in MS is actually unilateral rather than bilateral. So this picture summarizes what you need to know regarding these diseases. MS occurs almost in the middle one-third of the middle two-third of the optic tract, and it is mostly unilateral. And NMOSD, as the term itself says, neuromyelitis optica, that is aquaporin 4 related. So it is found in the lining the ependymal cells or the periventricular area. So chiasma is somewhat related to ventricular area. So it will be more near to the chiasmal region, and it will be more posterior, and MOG will be more anterior. So keep this picture in mind every time if some MRI is shown to you and it has a lesion like this. If unilateral, there is no doubt you should first think of MS. If bilateral and chiasmal region is affected, think of NMOSD, that is aquaporin 4 related, and the other one is the MOG, and it will be more anterior. If anterior, then papilla, that is the optic disc and all, will be more affected. Multiple sclerosis in the middle two-third and will be unilateral. For example, if this MRI is seen, so again I am asking you, what is this MRI? This is gray matter is white, so, and white matter is dark. So this is a T2 weighted image, and this is water within the eye. So this is water is white. So World War II. So this is T2 weighted image. In this T2 weighted image, you can see that this area is T2 hyperintense, and this is almost the middle two-third of the one side. So unilateral optic neuritis. I am not saying this is necessarily MS, because one lesion, this is actually gray matter. So no other lesions, but this could be MS rather than NMO or MOG. And this one is more likely to be NMOSD because we have the chiasmal and the bilateral involvement of the optic tract. So more likely NMOSD. And this one is more anterior and bilateral. This one could most likely be a MOG disease. And as I already told you, simultaneous optic neuritis is rare. But if it occurs, we have to think of other causes like MOG, NMO, toxic neuropathy, or Leber's hereditary optic neuropathy. And if in MS bilateral optic neuropathy occurs, it will most likely be asymmetric and will be severe in one of the eyes. And I'm talking more about visual problems because that will be the most presenting symptom in your MS patient. So that sensory and the visual symptoms are most common presenting symptoms. So if more than MCQ in your clinical practice also, we have to have to know this fact. Which of the following is unlikely in optic neuritis associated with multiple sclerosis? I'll start the polls. Question number 5. Straight direct question from Harrison. Yes. Okay. This desaturation, dyschromatopsia, diminished visual acuity are all usual findings, but there won't be any complete loss of light perception in case of multiple sclerosis. Most of them have answered it correctly. Some additional points is that optic nerve in the visual pathway anywhere could be affected because they are all tracts, of which optic nerve is the most commonly affected site. And the most common finding would be a central or the centrocecal scotoma. So the picture in the this HFA Humphreys field analysis would be a centrocecal scotoma. And you get a relative afferent pupillary defect because the optic nerve tract is affected. But as I told you, if you see that it doesn't reach, it is in the middle two-thirds of the optic nerve. So most likely it won't reach the fundus part. So usually the fundus will be normal, especially in the early part. So there will be no papillitis. It is actually retrobulbar neuritis. The patient will be having these kind of findings of all this optic neuritis as explained before. And patient will be having also pain while moving the eyes. And the fundus will be normal. So this is, the patient sees nothing. It's not nothing because there is no complete loss of vision. And examiner or the doctor doesn't see anything because there is no papilledema or fundus abnormality. And this is the usual finding in retrobulbar neuritis. And you should know that 90% of the patient regain the normal vision by about 6 months. And pallor of optic disc, optic atrophy commonly follows optic neuritis by about 1 month to 2 months after a optic neuritis. So you must have heard of Charcots triad. That is during the MBBS period, you must have heard of Charcots triad. It is associated with which disease? You can put in the chat box. Charcots triad is associated with, cholangitis, right? So what is Charcots triad to do with MS? As I told you, Charcots, this MS affects all these tracts. So we divide this, if it will be easier for you if you divide this affliction of MS into visual pathway disorders, cerebellar, sensory, motor, etc., etc. And what is this Charcot triad in MS related to? And first of all, you have to know what is Charcot triad. Those who know can answer. So seeing the chat in between, yes, some have answered. Hemant and Yamini have answered it. Yes. Yes. So Charcot's triad is a triad consisting of nystagmus, intention tremor, and scanning or staccato speech. Now, if I tell the triad, it will be very easy for you. So now it's easy for you. That is, it is the cerebellar pathway. So it is nothing connected with visual or sensory. Most of them answered that like that, but it's associated with cerebellar. So this could be one of the presenting symptoms. You may think that this, multiple sclerosis always presents with Lermite symptom, orthophenomenon, presents with spasticity, hyperreflexia, visual optic neuritis, etc. But it could present as a pure cerebellar symptom with nystagmus, intention tremor, and cerebellar findings like Charcot's triad. So that also you should keep in mind. So which one of the following is not a feature of multiple sclerosis? So, and which one of the following is not a feature of multiple sclerosis? Don't get worried with if you are getting new terms. It is good that you are getting new terms, and new terms means new knowledge regarding things associated with multiple sclerosis, because these could be asked and these are clinically relevant. That is why I have put these questions apart from what you read from Harrison. So some people think that Pulpridge effect is not associated with multiple sclerosis. Some think that dyschromatopsia is not associated. Everyone is of a strong belief that Lermite symptom is definitely associated with multiple sclerosis. So basic is thorough. So we'll build on to the basics. Don't worry. So if you can see, this is facial myokymia. And in the option I had put it's facial myarrhythmia. That is not a feature of multiple sclerosis. Facial myokymia. Facial myokymia usually is seen below the orbicularis oculi. And I have shown this video, that is below the orbicularis oris. That is also a facial muscle. But usually is most commonly could be seen that is a small undulating wave like twitching below here, that is in the facial orbicularis oculi, below the eyes. So facial myocamia is a clinical finding in MS. So don't think that is always if you see a facial myocamia it is always MS. No, it could be also a finding along with other findings of MS. If you find a facial myocamia, then it's MS. Otherwise, you also have to think of other lesions like a brainstem glioma near the pons or pontine glioma, etc. You have to think. And regarding Pulpridge effect, that is the reason why this question was put. This is actually a problem with the delayed optic nerve conduction. So as discussed above in the previous questions, you know that optic nerve gets affected. There is definite affection of one-sided optic nerve, that is unilateral optic neuritis occurs in MS. So optic nerve conduction is delayed. So in such a patient, what happens is that when light from one object comes to the eyes, one side of the one eye perceives it normally, but the other eye doesn't do that normally. It takes time. So there is delay in this process, and that apparent delay causes the patient to believe that something is wrong in the perception. So I'll explain. So you should know one thing, that in such a patient, the Pulpridge effect, what it causes is that the patient feels that everything is coming in a wrong direction. A two-dimensional movement is perceived as a three-dimensional movement, and the patient may feel as if something is going to come and smash onto him, because I'll tell you, this patient was sitting on a bus and it was moving straight, and another bus was trying to overtake this bus, but to him that bus was not going as a straight line in 2D, but it was trying to curve in because of the perceived perceived apparent deviation because of this Pulpridge effect. So if you put a pendulum in a case of a pendulum swing a pendulum in front of a Pulpridge effect, that is in a multiple sclerosis patient, this patient will have the feel that the pendulum is going in a anti-clockwise or a clockwise direction rather than swinging forward and backward. So what is it in the clinical relevance? What is this in clinical relevance is that if you see this picture, a patient sitting in the car, and as I told earlier in that bus scenario, the patient driving a car will have difficulty in driving because the patient feels that every time a car overtakes him, it is trying to bump onto him or hit him, either ways, if it is in the right side or the left side. So such patients, a multiple sclerosis patient, will have difficulty in driving. So a driver getting a multiple sclerosis having optic neuritis or any optic neuritis will have difficulty in continuing his profession as a driver. So that is the importance. Hope this video is clear to you. It doesn't break. Can you see this video without break, or it is breaking in between? I think it's breaking. For me itself, it's breaking. Sorry for that. What I wanted to, you can see that even the eye as well as the face are actually having this rhythmic movements. This is actually oculomasticatory myorrhythmia. The condition in which we get oculomasticatory myorrhythmia is that I had put that option, this finding in option. That is the reason why I had put this video. That is seen in Whipple's disease. Just for your knowledge, I had put that option. So now let's see the question number 8. So we have discussed regarding the paroxysmal symptoms. We haven't been proper, but we know that because of this transient conduction block, we get this paroxysmal symptoms, and these could be Lermet symptom, which causes tonic contraction of face, trunk, and sensory disturbance in multiple sclerosis. These can be distinguished by These are difficult to distinguish because these could mimic TA, epileptic activity, etc., etc., and they actually subside by themselves. So how do you differentiate it? So it is based, if you have high index of suspicion that it is something else, we have to definitely go for an EEG. And if in case of this kind of symptoms, the EEG will be normal. So all of them have answered it correctly. This is taken from Harrison. So nothing. So Lermit symptom. So more about Lermit symptom. It is otherwise called Barber chair sign. So when the barber tries to flex your head for proper cutting of the hair, electric shock-like sensation goes down the spine. This is called Barber chair sign. So it is not a pathognomonic sign of MS. It is seen in n number of conditions. And you should have an idea that Lermit symptom is not seen in MS alone. It is not seen in even in vitamin B12 deficiency, cervical spondylosis, etc., etc. Can be seen in other symptoms, even like nitric oxide toxicity, etc. So keep in mind that. And while taking case, never forget to ask this Lermit syndrome in case a symptom if the patient is suspected to be MS. Two variants of Lermit phenomenon is reverse Lermit phenomenon, that is neck extension. So neck flexion causing electric shock-like sensation is called Lermit phenomenon. Reverse Lermit phenomenon is neck extension causing this kind of symptom. So that is usually seen in cervical spondylopathy. And another variant is called inverse Lermit phenomenon. Usually we know that this Lermit phenomenon goes down the spine. If it moves up the spine, it moves to the head, then it is called inverse Lermit phenomenon, and is usually seen in case of, it is very rare, and if found, it is seen in case of a nitric oxide inhalation, and this is called inverse Lermit phenomenon. So this is reverse Lermit and inverse Lermit phenomenon. So now we have discussed regarding MS pathophysiology, pathology, clinical findings, etc. So if MS occurs within the spine, if it extends to more than 3 segments, then you think of NMO, that is neuromyelitis optica. If it occurs within one segment and it is usually, it will be towards one side, that is laterality would be there, then the presentation would be like a Brown-Sequard syndrome. But the patient will most likely have symptoms like a band-like sensation over that corresponding cervical area or cervical or the thoracic area. So that band-like sensation in MS is termed by something called as MS hug, multiple sclerosis hug, MS hug. So that is a term given in Bradley, just for your note. It just means that a spinal MS will have our band-like sensation, usually what we get in a transverse myelitis, that is otherwise called MS hug. So as you know, MS, the risk of MS, if a sibling has MS is not common in our part of country because we are in a tropical climate. MS is more in the higher latitudes, that is in the temperate regions, and it is more common in females. And the risk of developing MS, one table is there in Harrison. There is high probability that this would be asked, and this has been asked previously also. If you study, if you know this table only, you will be able to answer. So if you have read Harrison, definitely you will be able to answer. Otherwise, it's very difficult. So in that table, at least remember the fact that parents will be having a 50%. And monozygotic twins, at least remember 3 of them. Monozygotic twins, 3, parents 50, siblings 25. That is the only 3 things I remember. Let's check whether I am right or not. So the answer here is 25. Yes, I think it's the right one. Yes, that is the right one. Yes, sibling, it is 25. So at least learn 3. I won't ask you to study everything because it's very difficult. So these 3 study for yourself. So identical twins 3, 1 in 3, siblings 1 in 25, parents 50. At least that you should remember from this table from Harrison. Which is the most common type of MS? So now we are going to the cause of MS. That is, what are the types of MS? relapsing remitting, secondary progressive, primary progressive, progressive relapsing. So now some people would be raising their eyebrows that they haven't heard about the fourth variety. Yes, there is a fourth variety, but I would like to say that it's not there is a fourth variety. There was a fourth variety, that is a progressive relapsing type of MS. Was there before 2013. But after 2013, that was included under primary progressive type of MS, and it was termed as primary progressive type of MS, active or not active. So before that, there were 4 types. Now there is only 3 types. So 90% of MS is relapsing remitting type, which we commonly see. And this was the previous classification. Now this is from Harrison, that is RRMS, PPMS, and the most common one is the RRMS. The least one is the primary progressive. And this is a very important question. So some areas, some alleles have got some susceptibility. So try to, this is a question from Harrison. I have included both Harrison and Bradley in this question. So try to answer this question. You may think, so read the question first, the structure of the question before answering, even if you think you know the answer. No, please read the question before answering. That is the very important thing. That is why, so the most probable wrong answer will be your first option. The most probable wrong answer will be your first option. So always think like that and read the question, even if you think that the option would, the question is pretty easy for you. If you see the structure, I am not asking for the most common risk factor allele for MS. That is the one which is given in Harrison. In the Harrison, they have clearly given the most common risk factor allele for MS is HLA-DRB1 1501. But in Bradley, they have given one more point that HLA-02, HLA-A02 is actually protective for MS. So that point I wanted to you all to know. So the first one is pretty simple for you. So that is, this gene allele is protective. These 3 gene alleles are actually protective for MS, are very high risk factor for MS. And this HLA-A02 is the only protective MS HLA allele. So this is from Bradley, the latest edition of Bradley, which is incorrect. So you must have read the etiopathogenesis of that etiology of MS. So many viruses are implicated, like CMV, HHV6, EBV, chlamydia, etc. And of which questions could be asked multiple ways. Which is the most common virus implicated in case of MS? What are the other factors, etc., etc. So the question is, which one is incorrect? Which is an incorrect statement. All are pretty sure that SOLAR trial proved the positive role for vitamin D. Okay, I'll leave that to be answered in the. So everyone thinks that's seroprevalence of Epstein-Barr virus when checked in the MS patient was found to be 99%. But the thing is that in case of normal controls also, it's very high. That is another thing. But seroprevalence in Epstein-Barr MS patients for Epstein-Barr virus was 99%. And SOLAR trial was a trial to look into the vitamin D efficacy in case of MS, whether the patient improved or not, but it failed. So some trials showed that vitamin D is beneficial, but the SOLAR trial is one of the largest trials which showed that there is no efficacy of vitamin D. And smoking increases definitely risk. And sun protection factor blocks 94% of incoming UVB. So this is one of the largest trials which didn't show efficacy of that is, they didn't improve the relapse rate or disease-free activity in case of vitamin D supplementation in case of MS patients. So what do you think is the which of the following factors show evidence of risk reduction in MS? So try to answer this question. Question number 30. So this module will be basically basics of multiple sclerosis. Next module will be going in deep. So gear up for the next module. Yes, coffee is the one. Coffee is the one. High coffee consumption has neuroprotective and anti-inflammatory effect. So in this, obesity is definitely causing high risk of multiple sclerosis. And you should know a proper night's sleep. If a patient or any normal person is getting a proper night's sleep, then this melatonin is found to be having a protective effect on MS. So if in case of shift workers, this melatonin activity will be deranged, and the person will be having high risk for multiple sclerosis. This is a pretty simple question, but read and answer. Read and answer the question. Don't jump and answer, just read and answer. Everybody viewing this should attempt, because it's a pretty easy question. Okay, well and good. No, still people who had took time and answered have got it wrong. I don't know. Yes, I'm giving much time so that everybody answers. I'll move on only if 61 of you answers. Give one attempt. Let's see. Okay. Oh. Okay, I'll just leave. Okay, most of them have answered it correctly. You should know that RRMS, that is relapsing remittive MS, which is the most common one, has found to be having this latitude, that is temperate tropical difference. That is, in temperate countries it is more, tropical it is less. And also one more thing is that in females to male ratio it is actually 3:1, 2 or 3:1. And one more thing about this primary progressive MS. This has a steady decline in case of MS. And this, in every place which we checked, which they checked, it was the ratio in female to male ratio was actually 1:1. So this was from Bradley, 8th edition. So MS in pregnancy is actually a very important thing and repeatedly asked question. So this is a repeat question. So that I suppose everybody would be knowing the answer. The MS relapse risk in pregnancy is maximum during which one of the following time frame? Is it first trimester, second trimester, third trimester, or postpartum 3 months? So most of them have answered it as 3 months postpartum, and that is the right answer. If you take this 9 months before delivery and 3 months postpartum, that is usually considered the time of pregnancy. The MS relapse risk is actually normal. There is no much change. Overall risk is normal. But if you segment this into first, second, and third, the most increased risk, higher risk is during the 3 months postpartum. And the way reduced risk is, the least risk is during the third trimester. So that is an important point you have to learn. This could be asked in either ways in case of MCQs. So as we have seen, MS diagnosis needs high index of suspicion, and we have seen the symptomatology for MS. And the criteria actually is getting revised. First criteria came in 1965, that is the Schumacher criteria. Then in 2001 came the McDonald criteria. All the criteria has got the basic backbone. That is, one is the main symptomatology, how it presents. Then the evidence, that is the evidence of CNS involvement. Then all must have heard dissemination in space, dissemination in time, and there should be no other causes of MS like vasculitis, other NMO, MOG, sarcoid, other infectious diseases, etc. So these are the main criteria. So if you have in your mind, these are the main backbone of the criteria and then study, it will be easy for you. Of which dissemination in space and dissemination in time are very important. Others you will know. So the three typical syndromes of MS usually are, as we have discussed, is optic neuritis, brainstem syndromes, and transverse myelitis. Of optic neuritis, we have discussed in large. Then brainstem syndromes will involve the usual ones, that is the INO, bilateral INO, the cerebellar symptoms, nystagmus, etc. Then the transverse myelitis, which will be limited to less than 3 segments. So as we know, as I told you, 1965, the Schumacher criteria, 2001, the McDonald's criteria. In 2010 came the Polman modification of the McDonald criteria. And latest, and what we follow now is the 2017 revision of the McDonald criteria. So the lesions where we look for MS is in certain regions. So if you have multiple lesions in the brain, if the whole brain is in having multiple MS lesion, even then we classify the lesions as in specific areas. If that areas have MS, then we categorize it as MS specific lesions. So which one of the following area was newly added to the 2017 revision of the McDonald criteria? So before that, what were the previous lesions, we have to know. So if you are aware of the previous areas, you will be able to answer, but I have kept the options a bit confusing. It's okay, but all the options have got its own significance for you to understand. So yes, very good. Most of them are answering it correctly. I'm happy to see that. Most of them have answered it as cortical. That is the right answer here. Because you know the previous areas in MS, yes, they are the juxtacortical. So you must have heard these juxtacortical, periventricular, infratentorial, spinal, etc. Spinal, there is no confusion. Infratentorial means just below the tentorium. So it will include all those below the tentorium, including the cerebellar. And periventricular needs no further explanation. That includes the Dawson's fingers. So questions on Dawson's finger, why it occurs, perivenular, cuffing, etc., will be asked. And what is this juxtacortical? And what is the difference between juxtacortical and cortical? Just for your knowledge, juxtacortical means it is just near to the cortex, abutting the cortex. It is otherwise called subcortical U fibers. This way you will hear it mostly in case of pediatric neurology and also in adult neurology. But this is the juxtacortical region. So this is the cortex, which is actually gray matter, not white matter. So we are talking about white matter lesion. So this one is actually the juxtacortical lesion. And what is cortical lesion? So MS being a white matter disease will be having cortical lesions, and these cortical lesions in MS are difficult, actually are difficult to find in case of a with a normal MRI, and we need a high expert interpretation and high Tesla MRI to detect cortical lesions in case of MRI, in case of cortical MRI MS lesions. So juxtacortical, periventricular, infratentorial, and spinal, of which we don't consider cortical as separate. Juxtacortical or cortical is considered separate. So still there are 4 areas in brains regions considered specific as MS specific regions, of which the juxtacortical and cortical are considered together. And dissemination in space is very important, because we want to brand it as MS. Otherwise, a patient coming with a single disease or a multiple episodes with a history of multiple varied symptoms, we have to brand it as MS. So for that, the lesion should be having dissemination in space, which is actually 2 lesions, 2 MS typical CNS lesions. That is 2 out of 4 should be there. So remember this, 2 out of 4. And dissemination is time is based on the contrast enhancing and non-contrast enhancing lesion in a single MRI. But if you are getting a follow-up MRI, we have to have 2 different lesions, or you have to wait for a second attack if that is for a clinical dissemination in time. So this is the 2017 modification. So what this is because of lack of time, you can read through. You have to. I think it's better to know the few points that this oligoclonal bands came into being. So oligoclonal bands have come is important criteria. So any patient with MS, if you are confused with the diagnosis, don't wait. Go for a CSF oligoclonal band testing. That will help in the removing the confusion, especially in case of first attack and the patient is we are doubting that the patient is having a clinically isolated syndrome, which I'll discuss further. And cortical lesions, as I told. Okay. So it's very easy. If you see this table, Bradley has also one more table. I think I have added. Yes, same. If you can see, but it's big cramp. You can follow this table and see if you want. So we'll. So just try to. It's pretty easy for you because I haven't made any confusing options for this. So try to answer. Just read the question. I want you to read the question. So this is a patient presenting with MS-like features, and MRI shows a periventricular hyperintensity with no other evidence of MS. So what will you call it? So any lesion, any patient with first attack of MS, MS-like symptoms, without any clinical, without any MS criteria fulfilling radiological findings, we call it as a clinically isolated syndrome rather than a radiologically isolated syndrome. And a patient with migraine was evaluated with MRI brain. So in a patient was having continuous chronic migraine, and the physician had thought of looking into any causes of this secondary causes of migraine. And on imaging, he was found to have this kind of findings. That is typical of MS. So what do you call this? So you can see this. These are Dawson's fingers, infratentorial lesions, spinal lesions, contrast enhancing lesions. Everything is there. Yes, but the patient has just got migraine. So this we cannot call MS because he had just a clinical single attack of migraine, and single it's not attack is not typical MS attack, and it's just a migraine he was continuously having, and it has nothing to do with MS. And incidentally we got the finding of a radiological finding of MS. So this is actually a radiologically isolated syndrome and not a clinically isolated syndrome or even a multiple sclerosis. So so know these points about CIS, and you should know one more fact, that this radiologically isolated syndrome, the patient, migraine patient, as in this case, if the MS lesions are typical of MS and fulfills this criteria of McDonald's, etc., radiological wise, there is a 34% chance that the patient will, after 5 years, that is within 5 years, will have MS-like symptoms. So that is one more important clue finding. So we talked in large about CSF oligoclonal bands, which have become a star with the latest 2017 guidelines. And one more point I would like to say, that even though optic neuritis is the most common finding in multiple sclerosis, it has not been added in this MS specific lesions in MRI, because that you have juxtacortical, infratentorial, spinal, cortical, everything is there. But even then, this anterior visual pathway is not included even now as a MS specific lesion to be accounted in while considering the dissemination in space. So if a patient with optic neuritis have a lesion within the optic nerve, still we don't consider it as a one of the criteria, even one of the criteria. He needs to have either more than 2 lesions, either in the juxtacortical, infratentorial, spinal, or other areas to fulfill the criteria of MS. That is one more point you should keep in mind. So answer this question. You must have read this question by now. Okay. Yes. CSF oligoclonal bands are found in more than 75% of patients. That is true only. And OCPs may be absent in the initial phase of MS and will come, actually it increases with time. That is the important point. It doesn't decrease with time, it increases with time. And if the CSF shows more than 75 cells, or if protein is elevated, we have to have a high index of suspicion whether it's not MS or it's any other disease like inflammatory disease or infectious disease. So that is the important point. This question was taken from Harrison. So while reading Harrison, have this MCQ orientation of answering the questions. So if you can write the questions by side, paste stick notes by the side of Harrison, or even write notes by the side. So this was what I was talking now. It is in Harrison, it has given more than 75%. So this is from Bradley, which shows that the OCB positivity is actually 85 to 95%. I think, okay. Which is the most likely diagnosis from this MRI? Which is the most likely diagnosis from the spinal MRI? Sorry, I didn't put the polls. Sorry, not this one. Okay. What do you think is the most likely diagnosis? And can you tell me why you put this diagnosis? Anyone in the chat box? I don't think we have enough time to, yes. Somebody have answered anterior spinal artery. No, why do you think it's anterior spinal artery? It's actually to one side, right? So it's actually lateral. So you see again, NMO is the same table. It is NMO, MOG, etc. will be more of to one more bilateral. MS is kind of unilateral. And as I told you, vitamin B12 will be having most posterior column affection, and anterior spinal artery syndrome will have the typical owl eye sign. If you see here, anterior spinal artery will have the owl eye sign, and it is not typical for anterior spinal artery occlusion. It can be seen in cervical spondylitis, viral myelitis, one more syndrome associated with I forgot. So many syndromes are associated with owl eye sign. So remember that. So multiple NMO, it will be bilateral. Vitamin B12 deficiency, it will be posterior and posterolateral. Multiple sclerosis, it will be towards the one side. So it will, if you consider midline, this will be most likely one side. Yes. So that is one question. Owl eye sign. So which among the following investigation has the highest sensitivity for multiple sclerosis? Which of the following investigation has highest sensitivity for multiple sclerosis? So these are, my MS is actually white matter tract lesion. And all these evoked potentials look into the conduction along these white matter tracts. That is, brainstem evoked potential is brainstem auditory evoked potential looks into the auditory pathway. SSAP along the tracks, long tracks. BEP along the visual pathway, and MRI, as you know. So what do you think? Yes, I think I had misplaced the slide. The slide, most of them have answered it correctly. It's in the MRI. MRI is the most common, most sensitive among this test. So I have ordered the slides according to their sensitivity only. The most sensitive is MRI, followed by VEP, visual evoked potential, followed by SSEP, followed by BARA. So if you see the options here, so most sensitive is MRI, then comes visual evoked potential, then SSEP, Then comes Bara. So visual evoked potential is evoked potential. We look into the P100 latency. So if there is loss, there is demyelination, there will be prolongation of the P100 latency. So P100 itself says that the normal latency is usually 100. If it is prolonged more than 10 or 10 times, more than 10, that is P100 becomes P100, 110 or 120, then it shows that it is prolonged. Then it suggests that patient has this MS or optic neuritis. Which among the following is rather benign? It doesn't show that it is benign, but out of which is the benign demyelination? So these are the types, other variants of MS. Read the question and answer rather than jumping into answering. Marburg's variant is actually a highly acute variant of MS. If not treated properly, it is highly fatal. Ballot's concentric sclerosis and Schilder's variant is another name for Marburg's, which was previously used. Hence, I just put the name. So Ballot's is the one which you need to. So this is the Marburg's variant, and this is the Ballot's concentric sclerosis. These alternating rings are due to demyelination and remyelination occurring, and it could be self resolving. So I think this was an introduction to multiple sclerosis. Further, very important topic is regarding the DMR, the disease modifying drugs in multiple sclerosis, their side effects, and the latest ones, that is NMO. And also we'll touch upon the pediatric demyelinating disorders in the next class. So I think we have exceeded more than 1 hour for this. So hope you have got an insight into multiple sclerosis and other demyelinating diseases. Hope this video helps you read these Harrison as well as Bradley. Bradley concentrate on the chapter, on the tables, and then now new Bradley is actually well organized. So don't waste time. Read Bradley and Harrison. Okay, thank you. Thank you, Mansi ji. So we'll call it a day. Thank you.